Welcome back to the annual meeting of Women's Cancer with SGO, and we're going to speak a little bit about endometrial cancer and surgical procedures and other treatments. And I'm here with Dr. Dowdy, and I'm going to have him introduce himself.
My name is Dowdy. I'm a gynecologic oncologist at the Mayo Clinic in Rochester, Minnesota.
Yesterday, you were part of a pro-con discussion with Dr. Powell, which is also an interview on the site, and you were talking about specifically endometrial cancer and surgical care. Can you describe a little bit what you were talking about and some of your opinions that you were presenting?
Sure. Well, there's not really a standard of surgical care for women with endometrial cancer, which is a bit of an embarrassment since it's the most common gynecologic malignancy. So in order to push the field forward, the debate was about which group of patients we should study in endometrial cancer to really learn something and change our practice. So that's what the debate was about yesterday.
And yesterday, part of the things you were starting to discuss is what to do with the lymph nodes ultimately for the patient. Can you describe what the decision the physicians and the surgeons are having to make when they do that, and then what are some of the questions that are being answered that help them make those decisions?
Okay. Well, there's a wide variety of thoughts about removing lymph nodes. So in parts of Europe, physicians will do hysterectomy only and not ever remove lymph nodes and instead treat them with radiation therapy. In the United States, we're a little more heavily weighted towards removing lymph nodes and not radiating as many patients. And then there's institutions like ours that are in the middle, and we remove lymph nodes in patients who we think are at risk and don't remove lymph nodes in patients who we don't think are at risk, and they need hysterectomy alone and no radiation therapy. So there's a huge variation in treatment across the country and across the world, and that's what we're trying to reconcile.
When the final answer on what to do with lymph node dissection, what are the long-term goals for the patient? For a low-risk person versus a high-risk person, if you do unneeded lymph node resection or dissection versus you miss not doing something you may have needed to do, what are some of the risk factors that happen for doing it or not doing it?
Well, we don't want to undertreat patients because then they may have a worse outcome, but we don't want to overtreat them either. And so that's what a lot of our research has been is trying to figure out which patients we're overtreating surgically. And the reason that's important is if you remove lymph nodes and a patient is not going to benefit from it, all it will do is increase costs, it'll increase complications, and it also increases their long-term complications. So another project that we presented here, we showed that the risk of lymphedema, of swelling in the legs, is somewhere around the order of 1 in 4 to 1 in 5 out of patients who have lymph node dissection. And that's associated with the reduction in quality of life as well. So we had some hard endpoints like that to show that really if you don't need lymph node dissection, you shouldn't have it done because you'll have complications from it.
When a woman comes to you as your patient and is presenting with endometrial cancer and you're taking in for surgery, how do you talk through what you're doing and why you're doing that particular type of surgery?
Mm-hmm. Well, the only thing that any of us can agree on is that women with endometrial cancer need hysterectomy. So that's really the only thing that we definitively talk about before surgery is you'll have a hysterectomy. And then after the uterus is removed, our pathologists look at it and tell us the size of the cancer and how deeply invasive it is. And based on certain very strict criteria, we decide, and the operator, room, whether or not they need lymphadenectomy or not. So I tell them usually that they have like a 1 in 3 chance of not needing lymphadenectomy. So what we do at the time of surgery is dependent on what we find at the time of surgery.
As patients are presenting with endometrial cancer and they're going into treatment, what are some of the things they should be asking their doctor, specifically talking about their surgical procedures?
Probably the most important thing doesn't have to do with lymphadenectomy. It has to do with the approach to the surgery. So we know that patients that have a minimally invasive approach, either laparoscopic, robotic, or even vaginal, they have much better outcome in terms of their recovery from surgery. So there are some patients that are not candidates for minimally invasive surgery. Probably 80 to 90% are. And really, if you have a hysterectomy, it really should be by a minimally invasive approach. That's probably the most important thing.
Thank you very much. Thank you for your time, and thank you for your service to women.